Welcome back to our video series on pediatric respiratory conditions. In this video, we're going to provide a very brief introduction to cystic fibrosis. When you think about cystic fibrosis, or CF, think about pulmonary and digestive systems. This also includes the endocrine system, as we're going to talk here in a moment about. This is an autosomal recessive gene, so CF is a genetic condition. The basic pathophysiology in CF is the gene responsible for these systems changes the chloride channels that are present in your lungs, your digestive system, as well as many other systems as well. Instead of having nice thin mucus, you have very thick mucus, because remember, fluid follows sodium and chloride. Because fluid can't get into this mucus, it tends to be very thick and plugging. And this plugging is the issue, both in the pulmonary system, but also in the other systems. We'll talk about his here in a moment. On the left, you can see an illustration of normal airway. On the right, you can see an illustration of a cystic fibrosis airway. Immediately, you can see the difference in the green area at the top. Because of that defective chloride channel, there's a ton of thick, nasty mucus stuck in your airways. And the presence of this mucus is going to be responsible for a lot of the signs and symptoms and the treatments that you're about to see. So as we said, the mucus is way more viscous. This creates problems everywhere. But also, it allows us to test children very effectively for the presence of CF. In fact, we can test the amount of chloride in their sweat and find out whether or not they have CF. And as we talked about earlier, the dysfunction is related to the chloride channel, but sodium and chloride are both affected, and they actually work very closely together, as we know. So because of this thick and tenacious mucus, we end up getting less secretion of bicarbonate and chloride from the pancreas. The pancreas, if you just keep in your mind, is getting plugged with all of this nasty thick mucus, and it can't secrete everything you need to digest. So as we go through each system, think about this thick mucus and how it's going to affect each system that we're about to look at. Back to the pancreas for a moment. Many children develop cystic fibrosis-related diabetes because of the lack of insulin secretion. Cirrhosis is also common, and these patients have issues with their reproductive systems because of the role mucus plays in both of them. Every child with CF will have pulmonary complications. However, the onset and the severity of these are widely variable. This abnormally thick mucus needs to be removed before it causes mucus plugging, atelectasis, and hyperinflation of the lungs. And like we've talked about in other videos, any sort of stagnant mucus or water is an excellent environment for bacterial growth. And this is why our children with CF have recurrent pulmonary infections. These recurrent infections cause changes to the lung tissue and also to the pulmonary vasculature bed, which eventually lead to pulmonary hypertension, respiratory failure, and death. Many of these patients end up requiring a lung transplant. You can see some of the pulmonary manifestations on these lists here. Wheezing is caused by turbulent flow of air going past mucus. They typically say they can't breathe and have a cough. Mucus plugging inside of the lungs prevents air from going past the plug, which is what we refer to as atelectasis. And with progressive involvement, you can see a barrel-shaped chest, clubbing of fingers and toes, and like we said earlier, repeated episodes of pulmonary infections. Pseudomonas is one bacteria that you should always think of when you think of CF. Although there are many other bacteria associated with CF, Pseudomonas is probably the most classic example. But all of these organisms can be very difficult to treat. As we talked about earlier, there are not only pulmonary manifestations of CF. Some GI manifestations include large, bulky, and frothy stools, changes in the appetite, depending on how much effort they're putting into just normal body processes, weight loss, and tissue wasting. You can also see growth failure because of the issues that we have with nutrition and digestion. To treat the pulmonary complications of CF, we want to improve ventilation, which again is the actual work of breathing. We want to remove these secretions, and we want to treat any potential infections. When you think of CF, think of Airway Clearance Therapy, or ACTs. This involves thinning the secretions with a mucolytic, such as mucimist, or 3, 6, or 7% saline. You want to open the airways. Remember, if the airways are larger, you can get more out of them. And we accomplish this with bronchodilators. And we also want to expel the mucus, which involves the patient coughing, but also involves us helping them, such as with pulmonary vest treatments, coughulators, or similar equipment. This is an example of a vest treatment. The vest goes around the child and then provides a nice shaking motion, which helps rattle the mucus free and then allows the child to cough it up. They typically get bronchodilator and mucolytic therapy treatment with a nebulizer during these treatments. As we talked about before, it's easier to get something out of a container if you have a larger exit. In this situation, our airways are the exit for all of the mucus that's built up in their lungs. So we want to use bronchodilators, such as albuterol. There's also other medications that we can use that are nebulized, such as pulmozyme, which helps break down the mucus itself. Three, 6, and 7% saline is hypertonic saline. And when it's nebulized and inhaled, coats the mucus and helps to draw fluid into the mucus to thin it. It's important to know that whether it's hypertonic saline or mucimist, these treatments tend to be a little irritative and can cause the patient to have bronchospasms. This is another reason we give albuterol with these. Other treatments include antibiotics, sometimes prophylactic antibiotics that the children take orally all the time, or IV antibiotics when in the hospital. Many patients with CF are also on corticosteroids. We can give inhaled antibiotics such as tobramycin as well, and eventually, as we said before, patients may need a lung transplant. GI and endocrine treatment is actually fairly straightforward. Children with CF require a high protein, high calorie diet, not only because they don't absorb nutrients as well, but because they have an increased metabolic workload. Because the pancreas cannot secrete all of the digestive enzymes that you need, we need to administer pancreatic enzymes with every meal. And for CF-related diabetes, the pathophysiology is different, but the treatment and end result is actually very similar to type 1 diabetes, and we treat it using insulin. The median survival age for a patient with CF is only 37 years. The nursing care of CF involves a comprehensive assessment, and again, not only of the pulmonary system. The pulmonary system assessment would be similar for the child with asthma. You want to know what their lungs sound like. How hard are they working to breathe? How fast are they working? How comfortable do they seem? What kind of cough do they have, and what does it sound like? And are they getting tired? Or is their pulmonary symptomatology affecting their activity level? Please continue to the last video in the series where we'll talk about croup, bronchiolitis, and epiglottitis.